Thank you, Kaushik. That was an excellent video to start off with. I must say that I am really looking forward to this lecture, and I'm sure a lot of you are as well. I have to introduce Dr. Shamsi to you guys. I think many of you would already know him from before. He's a good colleague of mine. He's an absolute gentleman. I met him first during the IQE exam when both of us were examiners for the ORE OSCE stations, I think. And that's when we got to know. I managed to have a chat with him because he was manning the station right next to me. And we managed to get to know each other very well and realized that we had a lot of common interests, in fact, some common friends as well. And from there on, we've always stayed in touch. And to give you a small idea in a nutshell as to what he does, I mean, I just don't know how he manages everything, but he works in close association with the CQC. He works with the GDC regarding the guidelines and the FTP process he takes part in. He's also running the scheme for the VT training from being a VT trainer himself before. And he's also an IQE examiner. He runs a full-time practice. He's a principal dentist there in Staffordshire. So so you will be getting definitely a multidisciplinary view of the things that are going to change and what we're going to face in the coming future. I hope he's got lots of positive things to tell us, because I think everyone's slightly worried. But over to Shaam. I mean, there's nothing more but to we're all waiting to listen to him.
Thank you very much, Dr. Shaam.
You're welcome.
For a very kind introduction and your very humble words. I'm going to see if I can share my screen.
Yeah.
And is that coming up now? Let me just see. Is that coming up, Darshan?
Yeah, absolutely. That's great.
Okay, excellent. Thank you very much. Well, a very good afternoon, everyone. On a not so sunny afternoon in Staffordshire, but thank you very much for spending your Saturday afternoon with Dental Routes. My name is Shaam Shamsi. I'm your speaker. I am your host to a certain extent. I'm your colleague. I'm your friend. And this afternoon, we're going to be looking at ethical and legal considerations. The title that's been given to me is GDC and CQC, Where Are We Now? I'm going to extend that to various other bodies because as we've witnessed, as we've experienced, there have been a number of guidance and publications that have come our way in the last 5 to 7 days, so much so that I've lost the will to live in reading all these documents, to be honest. But we have to keep abreast of it. We have to keep up on top, especially with the fact that we are expected to resume practice from Monday, the 8th of June. So there'll be a number of things I'm hoping to cover. It is going to be an interactive session. It is a difficult topic, the GDC and CQC. Everyone has a cynical view, and I don't blame you, especially how they've operated over the years, but in light of how they've acted recently over the last 6 to 8 weeks. But there is a lot of positivity about them, and I hope to share that with you. So a little bit about myself. I think Darshan really has summarized it beautifully, and I'm very grateful to him. I am very blessed and privileged, for those of you that know me, to wear several different hats in the profession. Starting with the General Dental Council, I sit in the Fittest to Practice, adjudicating matters of professional misconduct. I also work for the Care Quality Commission as a specialist advisor. I'm affiliated with the Royal College of Surgeons of Edinburgh, so I'm heavily involved with examining of the MFDS. I'm also a training program director, Health Education England, so I run the Staffordshire scheme for foundation training, and I've been affiliated with that for the last 20 years now. And it's an absolute privilege to come into contact with new graduates who are our future generation. I also work for Dental Protection as a risk management advisor and presenter. And so this afternoon, this presentation, which I hope to share with you, will be an amalgamation of the different hats that I wear. As Darshan said, I'm based in Staffordshire. This is my practice, Horizons, my little baby, as I call it. I established in October '99. I qualified from the Royal London over 25 years ago. I met my wife there. She's also a dentist, although she decided to take a back seat when we were blessed with children. and she hasn't done any dentistry for the last, I would say, 18 years. Maybe she knew what the future of dentistry was like, I don't know. But she runs a very happy life at home, but keeps her foot in the door regarding the profession. In a nutshell, I have a passion, ladies and gentlemen, for education, for teaching, for sharing my knowledge, to learn from you, as well as, you know, giving you my knowledge and my skills, and sharing with you my experiences. And dentistry is all about networking. It's all about learning from each other. We will continue to learn until the day we decide that enough is enough. And the current crisis has certainly, for lots of people, including myself, provided an opportunity to reflect on our lives, to reflect on our current situation. We have taken life for granted, but this 6 to 8 weeks, perhaps even 10 to 12 weeks lockdown, has allowed us to concentrate more on ourselves, our family, our loved ones, and allowed us to identify what's more important in our life. And dentistry perhaps has now become a secondary thing in our lives. So where are we now? We've got a number of bodies that have been firing away at the profession, starting from the regulatory body, the GDC, then the Care Quality Commission, then Sarah Hurley at the CDO from NHS England. We've got our indemnity organizations also advising us and guiding us to a certain extent. We've had FGDP that issued their guidance recently. We've got BDA. BDA came up with version 1 of the toolkit, and then suddenly in the last 24 hours, version 2 emerged. And we've also had the Royal College of Surgeons, who've also published their document as to what they feel primary and secondary dental care practitioners should do on return to work. So in order to meet the aims and objectives and the learning outcomes of the GDC, we're going to look at the overview, first of all, of the timeline, what happened, how it happened, why it happened, what happened to dentistry on the most important day of our lives, 23rd of March, a reminder of what the functions are for the General Dental Council and the Care Quality Commission. And what about our compliance since lockdown? We've all been advised, directed to do certain things, and then moving forward with our profession, where does the future lie? So we will look, obviously, at the obligations that you and I have in line with GDC and CQC. We will also look at risk assessment, not in so much detail because that's going to be personalized to your practices. And prior to Monday starting, we need to actually have those documents in place and ensure our staff adhere and comply with them. And mentally, sort of, how do we prepare our practices? And more importantly, how do we support our team members? Because it is a very difficult time for everyone concerned. Again, just to ensure that we meet the criteria, this is a presentation that will comply with GDC development outcomes A, B, and D. So let's just take a step back and look at pandemic in general. All of us know about the various pandemics that the world has encountered. But more sort of recently, if we look at HIV and AIDS, which emerged in the 1980s, there was a big uproar in the profession and the healthcare, how we need to manage these patients, how we need to be on guard, what infection control procedures we need to implement, the risk of transmission. Then we had obviously emerging concerns around CJD and the proteins that derive from that and how it can affect our infection control procedures, which sort of patient groups are going to be vulnerable. Then we had the SARS virus in 2002, 2003. And so, you know, this is not unfamiliar territory, ladies and gentlemen. We've been there. And as soon as these pandemics emerged, there was a little bit of panic in the profession. There was lots of guidance and publications as to how we need to manage such situations, our practices, what systems we need to put in place. And then it phased away. Evidence-based, the links were sort of hearsay rather to say that there was firm evidence. And although there may be some links around there, dentistry was considered to be safe. And the reason for that is because we have adhered to very stringent infection control procedures. We have processes in place to protect ourselves and our staff as well as our patients. And now the coronavirus, COVID-19, which again is a pandemic, yet there are still studies, research has been carried out as to its nature, as to its sort of etiology, as to its spread, and as to its sort of mutation rate. You know, there's a lot more that's still coming to the surface about this. And I am hopeful, and I pray to Almighty God that as much as we've been exposed to a number of pandemics over the years, that this is just another one of those that in time the profession will remain unified, will be able to move forwards with unity and strength and maintain all the compliances and the adherence to the infection control safeguards that we need to put in place. Again, when we look at evidence base, what is the evidence that has been brought to our attention regarding coronavirus? It's still in its early days. Even scientists are putting their head out trying to find out what's happened, why it's happened, how it's linked directly to the medical profession, the dental profession. So at the moment, the evidence is early onset. It's still emerging. There's still a lot to be done. So you could consider that evidence to be weak. Again, if we look at the timeline, December 2019, this is when it hit our screens from Wuhan in China, the COVID-19. There was a huge outbreak. Approximately a month later, Heathrow Airport, they started screening of people arriving from Wuhan. Britons from Wuhan were quarantined in the Wirral for 14 days. You may remember that. A 53-year-old super spreader returning from business trip to Singapore via Austrian ski resort. And then the first UK death was confirmed in February. I think it was around the 13th of February. Sorry, the first 13 cases. The first 13 cases came to light in February. It wasn't until the 5th of March that a woman in her 70s was the first victim of coronavirus, and she died in the UK. So as we can see through that timeline, there's been a number of things. The disease has progressed. A number of cases increased, people becoming infected, and it went into thousands and thousands and thousands. And that's when the government decided to implement measures, very slow to begin with, in my personal opinion, but then they realized that life has to literally come to a stop. Social distancing has to be implemented. Businesses, shops, retail shops need to be closed to protect the wider public. And again, this is just reinforcing that timeline, and then the government intervened by not only implementing lockdown, but introducing packages, financial packages for the residents of the United Kingdom, business packages to help further staff, businesses themselves, the grants, etc. So lockdown literally commenced and was continued on a 3-weekly basis. And when we're talking about evidence-based, we sort of refer to what research and what documentation that's out there. I mean, there are, again, emerging studies, but there's one that I would like to share with you, Dental Schools Council, COVID-19 returning to student-led dental clinical treatments. And again, it's just talking about the particles that are most likely to penetrate the lung and cause infection, minute as they are. But SARS-CoV-2 is not considered to be an airborne virus. This only becomes an issue when aerosol is generated by the patient or the procedure. And recently the faculty issued in their guidance information around aerosol generated exposures to take it one step further. Again, there's very few studies in the literature related to dental aerosol. What is important is eye protection goggles. They do receive more contamination from splatter or aerosol than masks. So again, we need to be vigilant. We need to implement safety measures. Again, if we look at the studies around, and this is a good study by Vina et al. In 2015 about the use of ultrasonic scalers and the aerosol that's generated after 15 minutes, and the distance that it passes. And then obviously after 30 minutes post-cessation procedure in the normal ventilation, there's no evidence of any air contamination. I personally believe that there is going to be more evidence coming to light. But at the moment, this is, it's weak and not enough studies have been carried out. We also have heard about the deaths taking place in the United Kingdom, in particular of the NHS staff. There was this concept that those that are working in the front line in hospitals, in direct contact with patients, perhaps their mortality rate was a lot higher. Well, the data, ladies and gentlemen, does not clearly show that healthcare workers are dying at rates that are proportionally higher than other employed individuals or even the population as a whole. So I hope that over time, eventually, people will soon forget the context of COVID-19 and what was happening at a particular time. My children, I'm blessed with one son who's 19, my daughter 16, and my youngest 10 and a half. You know, for them, it's a historical thing. Why? Because they don't have to go to school. They don't have to go to university. They're enjoying this very long vacation at home. But they certainly put it down in history. It's one to remember. 15, 20 years down the line, perhaps even 5 years down the line. If this virus has reduced in significant amounts, then we will just look back and think, yeah, you know, we can recall the impact it had on the world, and then life just moves on swiftly. Dentistry, well, we've in this time of lockdown has provided us an opportunity to reflect. This downtime has given us an opportunity to think about, you know, our work, our lifestyle, our routine. Certainly many of us were working very hard, running our practices, working with our teams. And then suddenly we've had this period where life has come to a halt. Yes, we've been triaging from our practices, but it hasn't been to the extent of capacity that obviously we've been working outside COVID-19. So many of us, and the number of people I do speak to, have now come to that realization that actually, I'm not looking forward to going back to work, or I'm not going to go back to the extent that I was working previously. Perhaps I want more time for myself, more time for my family. Maybe I don't need to work full time. Maybe I can work maybe 2.5, 3 days a week and be satisfied with what I earn. But we now need to understand how dentistry is going to move forwards and how it will impact in the future. And I'm sure I'm not the only one who's ended up with a migraine on a day-to-day basis. The moment you've read one guidance or you've skimmed through that guidance only to find another set of guidelines have been published from whichever body. And it's just one thing after another. So we need to ask ourselves, what will happen in 2020? Where will dentistry be going? And if I could give you the answer right now, ladies and gentlemen, I'd probably be a millionaire. The reality of the situation is no one knows where dentistry will be going. What we do need to do is be vigilant. What we do need to do is safeguard our practices, our staff, our patients. We need to implement all measures and systems into place to comply with the national guidance, not only to protect our teams, but to protect ourselves, because very often we forget of ourselves. And when we come home, we expose ourselves to our family members, members that could be shielded, vulnerable groups, elderly. So it's a whole picture that we need to really understand. And I'm sure this is an expression that many of you can relate to. Guidance after guidance. On the 25th of May, the Scottish Dental Clinical Effectiveness Programme issued their document on mobilisation of dental services, a guide and implementation, tools for general practice when we go back. Then the British Association of Private Dentistry in May, in the same month actually, issued their document of how practitioners need to prepare on return to work. And then our beloved Sarah Hurley from the CDO made her announcement, come back on the 28th of May because she disappeared for a considerable period of time. Some thought she was quarantined, some thought she had quit the profession, some thought she had resigned, and there was rumors going around. But on the 28th of May, resumption of dental services in England was announced. And it was really to slowly gradually introduce people back to the profession. The faculty followed on the 1st of June in their 68-page document, I recall, and then the BDA issued version 1 of their toolkit. Hence, they've now released version 2. But the important document at the moment, in my opinion, is to understand, to digest, and to implement the version 1 published on the 4th of June by the OCDO. And I'm not here to summarize that because everyone's got access to that. The reality of the situation is we need to adhere to. And there are going to be many aspects of there that it's going to be a team-based approach. It will require consultation with your nurses, your receptionists, your practice managers, your dentist to make sure that we adhere to that guidance. So the reality of the situation is that the OCDO has very clearly stated that we support the full resumption of routine dental care in a way that is safe, operationally deliverable, and allows dental practices flexibility to do what is best for patients and their teams. Central to this is the acknowledged clinical judgment of practitioners and their ability to risk manage. And that is a very key phrase. The acknowledged clinical judgment of practitioners and their ability to risk manage. And let me tell you now, the moment we return to our practices on Monday, the 8th of June, this risk management, this risk analysis, this risk evaluation, this risk assessment, ladies and gentlemen, will be an ongoing process. People like you and I will become experts in the field of risk assessment, over the next coming months, possibly even years, depending on how long this pandemic will remain. So we need to ensure that we implement this with robust systems and be prepared to visit it over and over again. So which guidance do I follow? You can pick and choose whichever you want. At the end of the day, the majority follow the same theme. Some are more extensive than others. The important thing is that, and the recommendation I can make is that we follow the national guidance by the OCDO. You will be expected by the regulatory body and Care Quality Commission, and any lawyer for that matter, to follow that national guidance. Should a situation arise, something goes untoward, something that, for example, an adverse outcome has arisen as a result of managing our patients, or God forbid the patient makes an allegation, I've contracted COVID-19 from your practice, the ultimate thing will be how much we can rely on our standing operating procedures and the risk assessments that we have implemented. So we need to apply, we need to adapt this document to our practice, taking into account individual practice circumstances. Hence, risk assessing is all about personalizing and tailoring it to your working environment. And obviously, over the last sort of weeks, including months, I would say, there's always been statements that have been issued by the General Dental Council and Care Quality Commission, and it's concerned us, and rightfully so. We've been worried about, how it will impact on us if we step out of line. If we decide to open our practices and manage, certain patients because UDCs will not accommodate them, how do we deal with this? And statements were made by the Care Quality Commission in the early stages, just to say that we reinforce and support what the CDO has published in a statement, only later to find that they redacted that, they amended it, and left it to the discretion of the practice and the team. And we'll cover that. I'm going to be impartial here because obviously, working for the GDC at the Fitness to Practice and Care Quality Commission, as much as we, and including myself, have had cynical views in the past, one must always see the other side of the coin. One must always sort of understand that there's always two sides to the story. And although the statements that they have made haven't been helpful in the early stages, it's important that we see the authority board's perspective from all angles. And what this photograph is trying to sort of highlight is exactly that, really, where Prince William is communicating with the press. He's trying to convey a message. Perhaps he's answering a question. He's trying to provide some form of, an answer or clarity to a particular point that was raised. And we see that the capture in this image, which is from one angle, showing one finger up. And it doesn't portray a good image, does it? It doesn't really send the right signal. In fact, just looking at that photograph, one would think, well, he's brought the royal family into disrepute. This is very shameful. We would not expect that from a royal family member. And then when we look at it from a different perspective, then we can only see that actually the message is a lot clearer. He's actually trying to convey a completely different message, but we've only captured that from the second angle. And that's really what I wanted to share with you, that, with my GDC and CQC hat on, sometimes we need to understand where these bodies are coming from. They are there to support you, ladies and gentlemen. They have a duty of service, a duty of care, just as we have to our patients, but they are trying to make sure that everyone sort of practices safely. They want you to exercise professional judgment. They are going to leave it up to your discretion at the end of the day. And obviously, where safety concerns emerge, brought to their attention, at the end of the day, they want to protect the patients as well as you and your team members. So they do have your best interests at heart. So why the body? So let's just take a look at the General Dental Council. For those of you that have not visited this, 37 Wimpole Street, I regularly visit there because of my role as an FTP member. They are there and they have a function. Just let's remind ourselves what that function is. We've got the standards, the 9 principles there that are very important that we need to adhere to. And if we haven't read them, and over the number of webinars I've conducted over the last 8 weeks, it's amazing how very few colleagues of ours in the profession have studied the GDC standards. Let me tell you that our patients have access to the GDC standards from the GDC website. So if they're literally one step ahead of the game, they know what their rights are. They understand what their, what their rights are when they attend the surgeries to visit yourselves and I and myself and the team members. If we don't have an understanding, how are we going to manage them effectively? The primary function of the GDC is really to regulate the profession by ensuring all dental professionals are registered. We've had horror stories of people carrying out procedures and they're not registered dentists. I'm sure many of you can relate to press releases about people carrying out teeth whitening or carrying out procedures that literally fall out their scope of the practice. The GDC are also there to protect the public. They have a duty of care to the public. And so someone has to be in authority to ensure that the public have been harmed, there is accountability. And also to uphold standards in dentistry, ensuring public confidence is maintained. And I'll add to that, it's not just our public confidence, but also it's the professional confidence. We are living in a very litigious society, although I can tell you now things have dramatically improved over the years. But more importantly, we do find that the minority in the profession can give the majority a very bad image. So it's very important to separate those individuals, help them back onto the road of dentistry, give them the confidence, because everyone has their own personal circumstances. There could be mitigating circumstances. It's about supporting each other rather than penalizing. And over the years, we have seen the rise of cases, but I can tell you very happily that things started to sort of cease at around 2017, which is where the peak was. And since then, the number of cases have dramatically reduced, dramatically. So much so since the implementation of clinical case advisors triaging the complaints that are coming through, it has reduced the number of complaints coming to the GDC level. And we are now through clinical case triaging, filtering out those cases that have no place at regulatory level. What were the issues in the past? Well, again, without sort of going into much detail, you can see for yourself on the screen, a large amount of it was around professional knowledge and skills. Then it was putting patients' interests first, or breaching GDC standard number 1, looking at personal behavior, code of conduct, which was unfortunately on the increase. And then obviously you have the various other different sections. So what's the GDC's position in light of COVID-19? Well, if you switch onto their website, there are a number of entries they've made on the various dates. I think the most relevant one is where they link it to the Care Quality Commission, because obviously these bodies work in collaboration with each other. And the statement that they issued on the website was that the CQC have stated that they are concerned to receive reports from multiple sources that some dental practices are not following the CDO advice and guidance and are still seeing patients for routine care, including AGPs. If these reports are accurate, then dental staff and the public may be exposed to unnecessary risk of virus transmission. So where CQC informed of such cases, they will consider action using their regulatory powers. And this created a massive uproar. The profession is already very fragile as it is. Lockdown has been announced. People's livelihoods are at stake. Income has been stopped. We're worried not only about ourselves, but our families, our staff, and most importantly, our patients. The welfare of our businesses are at stake. Some are eligible for funding and grants, others are not. Those that are involved and work with the NHS have got some form of guaranteed income, albeit, scares of some abatement being mentioned from time to time. The Welsh especially implemented, I think, a 20% reduction, moving to a 10% reduction. Everything's in the air. And now we get this statement. And, you know, naturally, as dental professionals, we would be perturbed about hearing of this. So you could imagine that if you come across an ethical dilemma, and again, I'm sure many of you perhaps heard about this in your local area, that in the middle of COVID-19 pandemic, you discover that a local private practice is seeing urgent treatment patients instead of sending them to the UDC locally. In what circumstances would you refer them to the GDC or CQC? What action do you think will be taken by both these bodies? And these are sort of dilemmas that sort of came to light. GDC has always insisted that, you know, should we feel that there is a concern that needs to be raised about colleagues, especially in light of the current crisis, then we need to whistleblow. Is that whistleblowing justified? Do we have enough information to justify that? And I had a number of colleagues ring me, colleagues that I haven't even spoken to at all before, getting hold of my number through various groups and whatnot, just asking for my opinion on these matters. We've seen Blue on Blue, an article by my good friend Len Cruz, and you know, more whistleblowing cases are reported to the GDC than any other health regulator. Now, you know, putting my dental protection hat on, if a concern is brought to your attention about a colleague, and this is something we used to apply as a principle, where patients used to come to you, you identified very poor substandard dentistry, patient is concerned, patient's unhappy, you've confirmed that things are not as they should be. Before we start passing judgment on such situations, we need to understand what's happened at our colleague's practice. There's always two sides of the story. We need to understand that sometimes patients only give you half the story. The patient says, my dentist failed to diagnose perio disease, gum disease, and I'm suing him. Well, how do we know what information is in that clinical record that's being kept by her previous dentist? There may be a diagnosis, there may be a discussion of the findings, there may be a management plan in place. The patient simply failed to return to the practice. So unless we have full picture of what's going on, we shouldn't pass judgment. And my advice to you, in any situation, from past and in the present circumstances, until you have the full facts, my advice would be that, you know, you speak to your indemnity, because we may very well find that there is a bigger picture that needs to be addressed.
I'm so sorry to, hi, I'm so sorry to interrupt you. I just had a question coming from a colleague. Is it okay for me to ask you a question now? And you can answer it along the lecture, or do you want it at the end?
We could do it at the end, because we may find that the answer to it is going to come later.
That's precisely what I thought. Okay, fine. I'll let you continue on.
Thank you.
Then, yeah, no problem.
Thanks, Patrick. So guys, I have a question for you now, because the whole purpose of these webinars that we have with Dental Routes is, so much as the speaker is blabbering away, we want you to engage. We want you to interact with us. So the question is this, and be ready to put this on your chat box. You are an associate returning to work only to find that you have been informed no recommended PPE has been purchased for the practice. The team has been advised to wear normal PPE for all procedures, including AGPs. Despite raising this concern, you have been advised to get on with it, and you know staff and patients will be at risk. Which GDC principle refers to raising a concern if patients are at risk? So if you can go to your chat box, you know there are 9 principles. Tell me what your answer is. Which GDC principle relates to raising a concern if patients are at risk? Karen says number 1. Senthil says number 8. Liz, David, Chelsea, Vipul. So which GDC principle number relates to raising a concern? Some very interesting results coming through. Keep them coming in, folks. Keep them coming in. So some of you given more than one answer. Very diplomatic, Munis. I like it. Many of you said 1. Some of you have said 6. The majority of you have said 8. Excellent. Okay. So, ladies and gentlemen, the answer is 8. GDC principle number 8 is the answer. And it reminds us very clearly that always put patients' interests at first and act promptly. If patients or colleagues are at risk, and take measures to protect them. Make sure if you employ, manage, or lead a team that you encourage and support a culture where staff can raise concerns openly and without fear of reprisal. Make sure you employ, manage, or lead a team and there is an effective procedure in place for raising concerns, that the procedure is readily available to all staff and that it's followed at all times. And should the situation arise and there is no improvement, then take appropriate action, because these concerns will be related to all patients, including children and vulnerable adults. We've seen in the press, through social media, a number of patients managing their own dental problems. This raises a lot of issues, and perhaps that was what pushed the government to resume dental services. You can see one patient here who's actually a member of the NHS, an occupational therapist, who was suffering from a very nasty toothache. She's still working away, going to work, looking after patients. But again, because the dentist had to abide by the lockdown procedures and the 3A guidance that had been implemented, she continued to be in pain. So there were a number of patients who were taking matters into their own hands. We also know of one that removed his own tooth. Again, just as a reminder, taking a step back, what was our requirement? What were we required to do? So we were required to triage from our practice, implement a 3A approach, categorize the patients who were asymptomatic. What I mean by symptomatic is, whether they were actually suffering from dental symptoms, but they were asymptomatic in terms of COVID-19. Then we had symptomatic patients for COVID who were directed to specific centers. And we also had in our neck of the woods a specific dental advice line that had been set up where unregistered patients could go. So the question that we always ask ourselves is, what if I get this wrong? What will the GDC say? Well, in March on the 18th of this year, we have the GDC made a statement saying we have no interest in penalizing well-grounded professional judgments. And let me just reiterate that, well-grounded professional judgments about how best to meet patients' needs, including where that judgment is to reduce or stop activity. They then went on to say that expert advice on the clinical aspects of COVID-19 will continue to come from different bodies, but that guidance will inevitably not cover every potential scenario, and that's understandable. Therefore, dental professionals will need to continue exercising their professional judgment and weigh the risks in any given situation. So what they're really asking you to do is become a master of risk evaluation, risk assessment, risk management, because every practice is going to be different. My practice will be different to the practices of people listening to this webinar this afternoon. Their practices will be different to the practices in one part of the country. Every practice is not the same. So unless we risk assess, risk manage, risk evaluate, then we won't understand how we're going to implement this guidance, and we'll only be going in circles. So we understand that in highly challenging circumstances, professionals may need to depart from established procedures to care for patients, and that should concerns be raised, relevant environmental and human factors will be taken into account. So the process of determining whether it is safe will involve carrying out the necessary risk assessments and having regard to relevant guidance issued by the professional bodies, statutory bodies and the NHS. Again, where a concern is raised by a registered professional, it will always be considered on the specific facts of the case, taking into account the factors relevant to environment in which the professional is working. So again, we would also take into account of any relevant information about resource guidelines or protocols in place at the time. And this was issued around the middle of May. Let's take a look at the CQC's function. So on the chat box again, I'm going to ask you I'm going to ask you 2 questions. The first question is, True or false, CQC regulates a dentist? True or false, CQC regulates a dentist? So on the chat box, if you can answer true or false. I hope these answers are coming from yourself rather than copying your colleagues. Keep them coming, ladies and gentlemen. Some interesting responses. Okay, so true or false, CQC regulates a dentist? The answer, ladies and gentlemen, is false. CQCs regulate the practices. It's our regulatory body, the General Dental Council, that regulates the dentists. So staying on the chat box, can you tell me which 5 key lines of inquiry the CQC assess practices on? Which 5 key lines of inquiry the CQC assess practices on? So fire away. Which 5 key lines of inquiries am I looking at, or would I like to see? For those of you that perhaps recently ended your CQC inspection prior to lockdown, you'll be in a better position to answer this. So what are the 5 key lines of inquiry myself and my colleagues assess practices on? Karen says record management. Adam says most likely something arbitrary. Karen says safe environment. Senthil says, are we safe? Good. Senthil says, are we caring and effective? Bhav Patel says safe, caring, responsive, well-led and effective. Sharik says policies. David says safety, caring, well, I'm sure that says well-led. Amina says infection control, data protection. Haider, good to have you on board, says health and safety. Priyan says safe, effective, caring, responsive, well-led with question marks. I think you guys have pretty much nailed it. Ladies and gentlemen, there are 5 key lines of inquiry, and they are as follows. And this is what we assess the practices on. It is looking at how safe that practice is. It's looking at the effectiveness of it. It's looking at how caring the services are, the responsiveness of the practice to the patients, and is the practice well led? And very often, we 99% of the time find practices adhere to and comply with all 5 themes. Having said that, there are practices who may be adhering to, say, 3 out of those 5, but not so well in the other 2. And those issues certainly need to be addressed. And I'm going to share something with you very important, without obviously mentioning any names, keeping it anonymous. In a practice inspection that I conducted with a colleague in February this year, for those of you, a number of you perhaps I've lectured to before and you've heard this before. It was a beautiful practice, private practice. You walk in, this is somewhere in the Northwest, 3-surgery practice, lovely reception, lovely warm welcome in the waiting room, clean hygienic surgeries. You've got a staff room, you've got an office, you've got a decontamination room facility, you've got separate toilet for patients. Everything ticked the boxes. And it's almost like the very first image you get when you walk in, it's great. In fact, it's so great, I'd love to work there. Let me tell you that within the first hour of that inspection, it was a 6-hour inspection, huge concerns came to light. So much so that I shared my concerns with my colleague, and we felt that this practice needs to be closed down. Those concerns came to light even further as we investigated all other aspects of the themes. And we would expect, prior to lockdown, prior to COVID-19, that all practices implement safety, not just for the dentists, the nurses, the team members, and the patients themselves. A safe working environment for all concerned. But in this particular practice, there were huge concerns around infection control, single items being reused, pressure vessels not being inspected at their required intervals, decontamination processes inadequate. Now, these are the basics, ladies and gentlemen, that we need to adhere to. So you can now imagine moving forwards, once we resume services, there are going to be even more robust systems that we need to have in place because of the detriment and the potential for COVID-19 to spread. So, you know, we're there as a body to look after everyone. And if things are not in place, then we're not going to risk that. You know, your team members are valuable to you. Your family members are valuable to you. Your patients equally are valuable to you. So why do we compromise these things? So it's about commitment across dental regulators and commissioners, and we work with you. We don't work against you. If we find something is not in place, which needs to be, or perhaps we will give you feedback in such a way that we would say, perhaps you would like to consider implementing this in this way. That's the way we would like to work. So what is the CQC's position in light of COVID-19? Well, we understand that there may be inherent risks in carrying out care and treatment, and we will not consider it to be unsafe if providers can demonstrate that they have taken all the reasonable steps to ensure the health and the safety of people using their services and to manage risks that may arise during care and treatment. What is the general theme here? You and I know that it's all coming back to those risk management, that risk assessment, that risk evaluation that we need to put in place for our practices. Hence, very importantly, prior to commencement of services, for those that are returning on Monday, the 8th of June, we need to have a standard operating procedure, which you can adapt from the number of procedures that are being, that are going viral out there. But again, tailor it to your practice, the dynamics of your practice, the arrangements, the number of surgeries. You may have a 4-surgery practice and you may have 2 waiting rooms. You have a 3-surgery practice and only 1 waiting room. Every practice will be different. Your risk analysis will be different, and it must be in place prior to commencement. So this was issued on the 19th of May. And if we go one step further, the CQC then stepped in, making their position very clear. Previously, they had not. And again, people were concerned that, oh my goodness, now the CQC are on my neck. Now the CQC will close me down. And this is a very difficult time for the whole profession. So the CQC made it very clear that the decision to offer dental care services is one for the provider to take. So if that dental care service provider is going to offer services, that is a judgment call that only he can make. The CQC cannot require providers of dental care services to close unless we find clear evidence of the breach of our regulations. That requires consideration of the use of our powers under Health and Social Care Act of 2008. So they made it very clear that, look, guys, we're not here to penalize you. We're not here, to put pressure on you. What we want to do is make sure that if you are going to open, if you are going to provide services, and this started off with our private colleagues in the private sector who felt they just needed to come back, and a lot of that took place around sort of middle of May, as we recall. Then let's make sure you're safe. What systems have you got in place? How can we ensure the safety of everyone concerned? And it was reassuring to know from the CQC that, look, guys, we're here to back you. We're here to support you. You got any questions, try and approach us, but you're sensible individuals. You've been doing this all along. So hopefully we won't encounter any issues. So CQC regulate practices, not individual dentists working in the practice. And again, it goes on to explain in a bit more detail what Regulation 12 means: reasonably and practical to mitigate any such risks, that the premises used by the service provider are safe, equipment, medicines, or sufficient quantities of these to ensure the safety of service users and to meet their needs. So the outcome was, in conclusion, if a provider is able to open to the practice during the COVID-19 pandemic in a safe manner, that will meet the CQC fundamental requirements to be safe and well led in line with Health and Social Care Act of 2008, then you're not going to be in breach. Okay, you're not going to be in breach of those regulations. You're not going to be subject to enforcement action. Those of you that remember, we were issued with statements from, this one in particular was from London. I'm sure this went viral as well, where there was the threat of people who resume AGP procedures will be subject to the relevant contractual sanctions and the referral to the GDC. Oh my God. And, you know, these are sort of statements that already, like I say, you know, the profession is very fragile. People, you know, worried about their livelihood, their practices, you know, looking after their own families. And suddenly we get threatening statements like this. And we all know these were not welcomed at all. Then obviously we found that that was redacted. There was an apology literally within 24 hours. Following our email yesterday evening, first, we would like to apologize if this has caused any distress. Well, you're damn right it did. And it's been brought to our attention that a particular paragraph in the statement does not align with the instruction provided by the OCDO. Let me tell you now, the GDC probably weren't even informed or notified that they were going to be implicated in this. So there was an apology, there was a redaction. And, you know, we were also around the same day, I believe, issued with letters from different areas. Again, it went viral. This is from the Cambridge Health Authority, a more empathic and collaborative approach that, you know, tell us what your plans are when you're resuming services. You know, if you're going to be resuming services and you've completed a self-assessment, are you able to open and provide AGP? Are you able to open and provide non-AGP? Are you able to open and only provide the 3A approach? Because, you know, there are going to be some practices that fall into that category at the moment. So the reality of the situation is that it was a more welcoming letter, it was a more collaborative approach, and it was very welcomed. And it put really the London lot to shame. So that was the sort of the Cambridge one, and then following that, there were a number of other areas over the country that communicated in a similar manner. So what if I get it wrong? And going back to that sort of question that was always been in our mind is, what about the lawyers? Because, okay, GDC have made that position clear. CQC have made that position clear. What will the patient lawyers say? So again, as a reminder, from a medical legal perspective, we have a duty of care to the patient when providing their dental treatment. The standard expected would be that of a reasonable dentist in the same situation as you. And then we had guidance that was issued by indemnity providers. There's a number of leading indemnity organizations out there. I am affiliated with Dental Protection, but obviously DDU also issued their statement, so did the MDDS. And to be honest with you, they're pretty much saying the same thing, and that is really to exercise judgment, exercise discretion, exercise risk assessment and evaluation in whatever you do. So I can tell you from a dental protection point of view that it's reassured all its members working in England who choose to return to work, and that they will continue to be supported. And, you know, these are very, very strong, supportive words that we need to hear. Reassure that the indemnity provided by dental protection will continue to meet their regulatory and their legal obligations as long as they're in active membership. So keywords, active membership, and paying the correct subscription for the work that they will be undertaking. Should a complaint or a claim arise from the decision to reopen, members can request assistance. We will give you support and advice where needed. It makes reference, obviously, to the GDC statement, the CQC. Why? Because they want everyone to work collaboratively. They want everyone to work in conjunction with the national guidance. If you are continuing to work or decide to work without adhering or giving reference to that guidance, then you could be making yourselves vulnerable. And none of us would. No, I mean, there's enough information out there. One cannot say, I wasn't aware or made aware of that. Written SOPs, standard operating procedures, then you're consistent with the widely accepted evidence base, evidence of understanding and adherence to protocols by all the team members. You to show the process of care, the rationale of clinical intervention, and the PPE used, and we'll come to that in a little bit more detail. So I'm going to turn to ethical and legal considerations, because really that's what it's all about now. When we return to work, there are going to be a number of factors where ethics will play a huge part, as well as the legalities of it.
We don't have any free time at all today, but you can sit and wait in case someone cancels, or we can call you just as soon as there's a gap.
But I came in really early this morning to get here before you got busy. It took me ages with the roads being icy. Oh, come on, I only want a few minutes.
I'm sorry, but you should have phoned first. We're really busy and can't fit people in last minute.
Morning. Oh, it's cold out there. Hello, Frank. Haven't seen you in a while. Yes, I've been tied up at work a lot lately, but I had to pop in this morning. A bit's broken off that tooth that you were going to crown, and it's giving me a bit of jip again. I came in early, hoping you'd be able to fit me in for a minute or two.
Well, Amanda does the appointments.
We're booked solidly today.
Oh, dear. Well, I'm sorry about that. You're welcome to sit here and wait.
Oh. Do you think it'd be long?
That's very difficult to say, really, but we'll do our best. Or we could give you a ring if you'd rather not wait here.
Right. No. No, I don't want to miss my opportunity. I'll wait.
So this is a typical situation that some of us would probably encounter pre-COVID-19. Patient comes in, no notice, just walks in, fractured the tooth, can you accommodate me? And the majority of our practices have systems in place, have protocols in place to manage such patients. This particular situation, receptions perhaps could be a little bit more sympathetic, a bit more forthcoming, and accommodating the patient's needs. Yes, she's probably following a practice protocol, but her actions weren't very helpful. In comes Harry, the dentist, who pretty much diffuses the situation and tries to sort of accommodate the patient wherever possible by giving him an option, or one of many solutions. Ladies and gentlemen, that sort of arrangement now is no longer going to be applicable. We are going to have to make sure that our front doors are locked so that patients can't freely walk into the practices. Social distancing will have to be maintained. Only those patients who have appointments should be attending. There will be robust communication channels in place. Many practices have implemented contacting the patient by phone to say, stay in the car, and when we're ready, we will call you and we'll open the door. So we want to minimize any risk wherever possible. So gone are the days at present, for sure, where we can accommodate patients just coming off from the high street into the practice. So 8th of June, are we ready? And if we're not, that's fine. All right, that's fine. Because we don't want to be a hero if we're not ready. All right, we're not going to conduct and perform miracles. We're not going to go down that Superman t-shirt and compromise ourselves, compromise our staff members, and put our patients at risk as well. So there are going to be many practices that are not going to be ready, and that's absolutely fine, ladies and gentlemen, because you and I know that the announcement was made a little bit over a week ago. There have been huge concerns about the availability of PPE, huge concerns about making relevant staff arrangements. Schools, majority of them are still closed. Our staff members may have young children. So there are going to be concerns amongst them to, how do I come back to work? I don't want to lose my job, but I don't want the practice to struggle without me. So the reality of the situation is that for the last 8 to 10 weeks, we have been conducting the algorithm, the 3A advice approach, analgesics and antibiotics. And now we move to the phase of face-to-face consultations with our patients. And the recommendation is, as we all know, is that we address non-AGPs initially. So this is really referring to those list of patients that we've accumulated over the months. We all have accumulated those lists. Some lists will be a lot longer than others. Some will be 150, some will be 600 patients, depending on the size of the practice. And our duty of care for the initial period is to address those patients, especially those who perhaps have managed to control their symptoms through the 3A approach, but they still need to be seen. Symptoms are varied, they're intermittent, they come and they go. Then the next category of patients will be those perhaps that we refer to the UDC and they now need a follow-up. We have a duty of care towards those. And then slowly but surely we will extend our services to the rest of our patients. So the reality is that it's better for us to be fully prepared, not semi-prepared, not 10% prepared. Only when you know that you and your team are ready to fully engage, then you do that. If you're not, like the Cambridge letter very clearly stated, then we refrain from face-to-face consultations and continue to implement the 3A approach until we are ready. And again, it's all about communication. It's about informing your patients that you as a team are in the process of making those suitable arrangements. So at present, we're not ready, and there's nothing wrong with that. We need to look at our standard operating procedure. We need to look at the risk assessments, the staff training, including the concerns. We need to address any physical and psychological concerns that our staff members will have. And believe you me, there are many out there that have these concerns. And who else, ladies and gentlemen, are they going to turn to if they don't turn to us? We need to look at the PP arrangements that we have in place. What has the practice put into place for non-AGP and AGP procedures? Since the announcement, many dentists have then and only then started to contact suppliers. But by then, suppliers are in shortage, and we're now resorting to seeing what arrangements can be made for overseas. But not everyone is in that position to have all the relevant arrangements in place. So for others, it will take a lot longer. Others have invested in PP, some of which have turned into fake and scam because of what's going out there. People have been taking advantage of dentists and their practices and selling fake PPE. We also need to look at equipment, our checks. Only last week I was triaging only to find my suction had actually packed in. So the suction motor is frozen, which means I need to get an engineer out. So our suction unit systems, our chair systems, the pressure vessels, everything needs to go through robust checks. Medical emergency drugs, including the oxygen cylinder, defibrillator, everything needs to be revisited and checked. Anything that's expiring or is non-functional, we need to have it in place before we open those doors, because an emergency, medical emergency of any type can take place at any time. What are the arrangements in place for reception, for the waiting room, to protect the staff, the decontamination room facilities? And the recommendation is that if you have obviously 2, maybe 3 surgeries, even more, then decide what you're going to designate to a non-AGP and an AGP procedure. For example, a surgery that doesn't have ventilation or there are no windows, you may just restrict to non-AGP procedures, whereas opposed to those that do have adequate ventilation. So what is the layout of your practice? Look at the floor plan, look at how you're going to manage such patients, and obviously make sure that such patients are phased to minimize social distancing. What about the appointment diary structure? In our practice, we'll have a patient every hour. So 9 o'clock to 9:30, initially risk assessment, just discussion, just consultation of those patients that are on our list. Not even going to carry out any procedures because we don't know what the outcome of that conversation is going to be. And then we allow a good half an hour in between to completely turn that surgery inside out, from cleaning, sterilization, from top to bottom, to adhere to the guidance. So we're just going to take a little short break, just 5 minutes, so you can stretch your legs and perhaps put the kettle on. I'm going to connect up with Kaushik and Darshan to see if there are any questions so far. Perhaps I can try and address those before we move on. And then we'll move swiftly on to the second part of the presentation, which I reassure you will be a shorter session.
Hi, Shaam. There's a few questions from a single colleague. I'm sorry, I'm not sure how many of these questions you can answer. So I thought maybe we should restrict our colleagues to probably 3 questions per person. But I don't know how. Maybe you can summarize them all into one.
Yeah, I'll try. I'll have a look at them.
Sorry.
And I'm more than happy to formulate.
I can offer to read them out to you, but I thought maybe
I've got them in front of me.
Yeah, sure. Sorry about this. I know it's tricky.
No, at all. And these are valid questions. And the reality is that we're all going to come across them at some point. I'm just going to quickly just familiarize myself with the questions. In your opinion, how do I deal with a patient who should be shielded but insists he wants an appointment to see me as he's midway through restorative treatment and his condition is deteriorating? His decline referrals to the UDC setup.
While Sham's going through the questions, guys, I'll just tell you what an amazing session it has been till now, and some of the finer details for us to look into as we go into Monday will be the ones that he's going to come up with as we go off to the next session. But also, this is a wonderful lecture which is going to be happening next Saturday. And you all know the name, Ash Palmer. He's one of the guys, he knows the name of the game inside out. He knows how to do dentistry in the best possible way, keeping all the legalities, the consents, and the patients happy at the same time, and also making sure a business thrives in a very, very, very good atmosphere. So we thought after Shaam would have detailed us with all the necessary regulations we got to keep an eye on, Ash is going to take the time to explain us on how to keep all of that going and yet make our business a very thriving business, which is equally important for the goods of everyone. Because this is something that I always find people worried about, being very defensive in their approach, trying to be too worried about the regulations, and not offering patients the level and quality of dentistry, the level and quality of technology we have in dentistry today, and also not investing on the level of technology we can invest on in today's state to make that patient journey a wonderful journey. We all probably hear or see that there may be maybe 1%, 0.5% of patients who really complain or have a bit of an untoward attitude, but the rest 99% of the patients are extremely happy with us at all times. And there's no point in us letting them down, being extremely defensive in our approach. And how you do a very good level of dentistry, taking care of all the things what Shaam told us today. Ash is the best guy to summarize it. So guys, don't miss that lecture, which is on the 13th of June. That is next Saturday, exactly at 3 o'clock. By then, I think we guys would have got used to slowly getting back to dentistry, slowly starting to getting up a bit early in the morning, making sure we are just sort of facing up and warming up, and we'll be back to a routine business. Having said that, I will pass the screen back to Shaam to take on a few questions that some of the guys have asked.
Thank you, Kaushik. Much appreciated. The anonymous attendee who does attend a lot of my webinars, so it's good to have you on board again. I can see a general theme from my colleague, and he always raises good questions. There are some very good questions there. I'm more than happy to respond because there'll be some detailed responses. One thing I will pick up on is the movement developing among dentists to boycott the GDC for not reducing the AR fee. Let me please plead to you, do not, this has been a very debatable topic, and obviously it's frustrated a lot of dentists. If you do not continue with your registration with the GDC, you will not be permitted to perform dentistry, even if you are over 50% in that majority. The GDC are very strict. This is a body that regulates the profession. And as much as perhaps we've been disappointed in the way GDC have managed things, that we've had reports about them furloughing staff, but continuing to charge us for the ARF, you will recall, all of you, that in the last 18 months, the GDC reduced their annual retention fee from £890 to £650, okay? And we were very grateful for that move. Now, in the fitness to practice, there are a mixture of lay people, dental care professionals, and the dentists. And we are working behind the scenes very hard to work with our regulatory body, with people at senior level, to make them understand what the profession is going through and what they will be going through. So it's on our agenda. They are aware of it, and I am very hopeful that there will be some compassion showed by the GDC. I can't speak for them in its entirety, but it is work in process. But I do plead to you that you don't deregister yourselves thinking that overwhelming majority will be that they'll be able to continue practicing. You'll be having another thing coming. Amina made a very good comment. KN95 mask suitable for AGP. There's a lot of fake masks going out there. There are a lot of legitimate masks going out there. I personally do not agree with KN95 masks being suitable for an AGP. I took several masks when I went for fit testing over several days, only to find the KN95 is as hopeless as a normal surgical mask. It's not well fitting, it will not provide the seal, and it will put you at risk. It's something you want to keep away from. It would be a good idea if GDC-CQC set up a helpline to answer practice. Absolutely. If that could be established, that would be great. And who knows, as time progresses and once we go back, some form of a setup will be in place to support the colleagues in the profession. I will try and address those other questions in more detail through a more direct response. Munis, again, fantastic question. Few staff members are hesitant to come back to work and scared of the situation. Any tips and guidance to address that? Very quickly, Munis. We will have an obligation towards our staff. We have employment contracts in place. And whilst I'm not an employment lawyer, my suggestion would be that you try and create time to address their concerns and address them in a very empathic manner. There are legitimate concerns that staff have. It could be health related, it could be family related. This is a very difficult and challenging time. It all depends on the circumstances, and the last thing you want to be doing is imposing disciplinary measures to your staff members without being receptive to their needs and their concerns. And a situation where you've tried to address those concerns, you've given them some time to think about, and you provided perhaps some solutions. And if you're not getting anywhere, my advice would be then obviously to speak to BDA, who can obviously provide good employment law advice if you're a member of the BDA. You may find that sometimes speaking to your indemnity, provided they can extend that advice to that category, will also be accommodating. But by no means should you jump to any conclusions and find that your staff are then making allegations of discrimination and unfair imposed decisions. Kieran, very quickly, last one, then we'll move on. I have opted to redeploy to work in the urgent dental care centre, but there was a delay in my practice manager providing the reference for the paperwork, and hence I couldn't work in the UDC. Now it looks like the paperwork is complete. My practice will be opening on the 15th of June. Can I choose where to work? Again, Karen, really that's a matter of you to discuss with your principal. There may be provision in place at your practice where, due to a phased approach, not all surgeries are going to be utilized, not all dentists will be required to work initially. However, if you're not going to be working in your surgery with face-to-face consultations, your principal may require you to be triaging at reception. Again, it really depends on the local arrangement that you have in place with your principal. Some principals are more flexible than others. You're still sort of contributing service to the UDC. So it's a discussion really that you need to have with your practice principal, because that's your main place of work. Excellent questions, guys. Let's move swiftly on.
So you need to share the screen back again.
Yeah, lovely, Kaushik. Thanks for reminding me. So let's see where it's gone.
Yeah, it's right at the bottom.
Is it that one? No, that's the questions. I'm not sure if that's the one. Bear with me. Just bear with me. Let's bring that up. Okay, is that coming up, Darshan?
Yeah, perfectly. Absolutely fine.
Okay, so risk assessment. We've been mentioning risk assessment a number of times. Believe you me, ladies and gentlemen, this is going to be your middle name, risk assessment. This is going to be a name that will replace your wife, your husband, because everything you do is about risk assessment. You will be experts in risk assessment. And, you'll extend that to, your duties outside the dental surgery. Risk assessment has always been there as part of our day-to-day routine, now even more so. And, risk management, as we all know, though, for those of us that have been involved with quality assurance and clinical governance in our practice, and it is a team-based approach, it's about identifying situations in the practice, evaluating them, treating them, and monitoring them. And then we re-identify them. So it's an ongoing process. So there are going to be factors that influence a face-to-face assessment. Our previous measures not manage the situation. What is the COVID status of the patient? So we're going to be risk assessing our patients very, very carefully. Those patients that are asymptomatic COVID patients, so they're not carriers of COVID, they know they're not carriers, although my advice to you would be to be very cautionary. Every patient should be treated as high risk. A lot of our patients out there aren't even aware that they may have transmitted or they may have picked up this infection and be a carrier. Irrespective, we also know that there are people out there that carry the virus, but they don't exhibit the symptoms. So again, our risk assessment process needs to be robust, and we'll have to have a series of questions to analyze that patient on the phone prior to making them an appointment. And obviously then we can categorize how we're going to manage those. Obviously, we will come across those patients, and I think our colleague, the anonymous attendee, mentioned about shielded patients, or those patients that are clinically extremely vulnerable. How do we manage those? And again, you've got to think about that in your practices as a team, adhering to the guidance, implementing that guidance for those type of patients, because they need to be accommodated. Since the announcement on the 31st of May, coronavirus, people shielding in England are allowed outdoors from Monday. Well, those patients now need to be accommodated. It doesn't mean that we can refuse them. So if we have the right level of PPE and we've done a risk assessment, we can ensure that those patients can be managed very safely. What about our own health? What about the availability of appropriate PPE? And again, we've, in the last perhaps good couple of months, been inundated with the type of PPE that we need to think about for non-AGP and AGP procedures. What about our colleagues working in reception? How do we manage those? We need to protect those at the end of the day. Whether the planned procedure will be an AGP, what systems do we have in place? High volume aspiration, rubber dam use, so we're going to be carrying out treatment under rubber dam. We've already been educated about the use of mouth rinses that have very little effectiveness prior to the patient being managed in our chair. So there are a number of questions that we need to ask ourselves. If I don't have the right PPE to do the ideal treatment, for example, root canal treatment, can I justify taking the tooth out to relieve the patient of pain? If I don't have the right PPE for my protection, should I do what's in the best interest of the patient, even if it means putting myself at risk? Can I offer NHS patients private treatment for AGPs as an alternative to referral to UDC to provide the same treatment? Should I be sourcing my own PPE for my practice when there is a national shortage of it? And should it be going to other frontline places such as care homes and NHS hospitals? So there's going to be a number of questions that are going to be arising. And again, it's all down to your risk analysis of each and every situation. You may apply one theme for all. You may decide actually it's going to be on, each case is going to be judged on its merit, and only you as a team can decide that. I'm going to touch on consent because even more so than before, our consent processes need to be robust when we return to work. And there are a number of reasons for that. If we just remind ourselves what consent is, it's the voluntary and the continuing permission of the patient to receive particular treatment. It must be based upon adequate knowledge and the purpose and the nature and the likely effects and the risks of that treatment, including the likelihood of success and a discussion of any alternatives to it. Now, the key words voluntary and continuing permission. So if a patient decides to withdraw their consent during a procedure, during a treatment, that is exactly what they've done. And you cannot continue. And then as much as you would want to inform and educate and reassure the patient that perhaps it may be in their best interest to can't leave a tooth or a large open cavity or gum disease left untreated, the reality of the situation is, ladies and gentlemen, that patient has withdrawn their consent. They no longer have given you permission to continue. And if you do, you could be down for battery and assault. So we have to respect that, and respecting the patient's autonomy is a fundamental part of our work. Risk analysis, we talk about all the options, including no option, no action. So no treatment is always on the top of our list. Again, we would educate our patients of the risks by not providing treatment. So we have a greater role than before to educate our patients. And sometimes patients can't differentiate what is realistic or unrealistic. That's where we are, apart from being dentists, are educators as well as dentists. So consent, due to the current situation, there are many limitations on the patient. And so if we're going to be dressed up in PPE, there are going to be masks that we're going to be wearing. We know full well that there are things that can be barriers to communication. Patients like to see our faces. They like to interact and engage with us by looking at our eyes and the expressions that we have. So our consent needs to be even more robust, which will require more time, additional time aside, so we can obtain consent. You cannot rush these things. Hence the reason why when we return to work, we will be spending a lot more time in the communication process than the actual procedure or the treatment itself. So the next question I have for all of you, and again, this is for the chat box, is as follows. What constitutes negligence? There are three main areas that amount to negligence, okay, that constitute negligence. So we need to understand what those three factors are. So on the actual chat box, start posting your responses, folks, and tell me, in your opinion, what constitutes negligence. Unreasonable care, Bronya. Sharak, duty of care, Kiran, sorry. So what constitutes negligence? What are the three areas that we look for that constitute negligence, or perhaps failure to amounting to negligence? So causing harm, patient harm is caused, not acting in the patient's best interests. A breach of duty of care, failure to diagnose, providing inappropriate treatment, there's harm as a result. Duty of care, breach of duty was the patient harm, very good. Lack of consent. So it's great because this is a really good refresher, a reminder that we need to be aware of these things. Supervised neglect from Senthil, bad treatment against the patient's will. Good participation, guys. Really good to see that. Okay, so let me share with you the components for negligence. So we have to ask ourselves, first of all, did the dentist have a duty of care to that patient? Has that duty of care been breached? And as a consequence, was there harm? Did harm arise from that? So to prove negligence, a patient must demonstrate to his appointed lawyer or the governing body that on the balance of probability that the dentist owed a duty of care to the patient. And in many instances, sometimes the dentist didn't owe a duty of care and the ice cream van has just arrived. Was there a breach of that duty by not exercising reasonable skill and care? And damage? Did damage follow from that breach, either directly or indirectly? So it's quite extensive, but duty of care covers obtaining consent, confidentiality, record keeping, diagnosis, advice, treatment planning and the provision of treatment and post-operative care and instructions. So let's take a look at Monday, the 8th of June. Your practice reopens and this patient presents to your surgery, okay? A 76-year-old lady phones your practice today. She has been with the practice many, many years, regularly attending and lives within walking distance. She does not drive and doesn't like using public transport. She lives on her own, has been self-isolating for a number of weeks and is in pain. The upper right is curious, and from her symptoms, she's describing a diagnosis of irreversible pulpitis has been made on the phone. She needs a pulp extirpation if she is going to save the tooth. She is on bisphosphonates. She's in tears on the phone, just needs someone to help her. She's a 76-year-old lady, okay? A practice only, you've got hold of FFP2 masks, as FFP3 are short in supply. However, despite your attempts to get even these fit tested, your efforts have failed as there's no one to assist. And that's one of the common issues the profession is facing right now. Since the announcement, everyone's panicking, trying to get fit testing, trying to get fit tested themselves, become a trained tester. But, you know, there's inadequate supplies, there's adequate testers out there. And so people are now struggling to meet the requirements of fit testing. And so this dilemma is in your hands now. What are you going to do for her? How are you going to manage such a situation? Let's take another scenario. Jennifer, an air hostess, who's your patient. She's 27 years old, who presents with a swelling from a tooth. A week prior to lockdown, she commenced root canal treatment on this upper right first premolar with her own dentist. Antibiotics have been prescribed for the swelling through the practice's own triage system. Swelling has persisted, it's getting larger, it's extending to her eye. So the dentist at the UDC, where you referred her, advises the most reliable thing to do is to relieve the pain, is to take the tooth out, which she agrees to, and the tooth is taken out uneventfully. When she returns to your practice, the dentist asks about the missing tooth and wonders why it was not redressed at the UDC. After all, root canal treatment had been commenced. I wasn't given the option. Jennifer says, who now wants a replacement tooth urgently. The teeth on either side of the gap are restored and healthy. She's an air hostess. This is important for her. She wants an implant to replace it. She can't afford the cost of an implant, wants to sue the dentist. Has the dentist acted negligently? Does the dentist have to give the patient all the options, even where AGPs are only provided by the UTC in exceptional circumstances? Would it make a difference if there was no FFP3 mask and only a non-AGP extraction was possible? So, you know, these are the situations, these are scenarios that we will come across. And they're going to be challenging times for us to gather the information. Information that has to be obtained not only just from the patient, from where she was treated. Now, until all these facts are obtained, it's going to be very difficult for us to pass comment and judgment. And in many situations, we may very well find that we're going to be speaking to our indemnities for support and guidance. Patient has an issue, how do I manage it? There's stress that you don't need. 8th of June has come, there's lots to contend with, lots to deal with, including patient and other staff concerns, so many variables to consider. If we refer to the Bolam test, which is what we used to apply in the General Dental Council, the fitness to practice, it referred to a doctor is not guilty of negligence if he has acted in accordance with a practice accepted as a proper by a responsible body of medical men skilled in that particular art. Then we literally were presented with the Montgomery ruling. The Montgomery ruling versus the Lanarkshire Trust of September 2015, I believe. The doctor is under a duty to take reasonable care to ensure that the patient is aware of any material risks involved in any recommended treatment and of any reasonable alternative or variant treatment. The test of materiality is whether, in the circumstances of the particular case, a reasonable person in the patient's position would be likely to attach significance to the risk, or the doctor is or should reasonably be aware that the particular patient would be likely to attach significance to. I could share with you what the Montgomery ruling is all about. It will take a significant amount of time, but it's a very interesting reading. And in a nutshell, when we are assessing risk, we need to assess the risk that is material to that patient. What may be relevant to one patient may not necessarily be relevant to another patient, and that's where we need to apply the principles of Montgomery ruling. And the judge in the court ruling, they also said that we're not meant to overwhelm the patient with information. So it's really making a balanced decision on how that patient would perceive those risks if they were material to it. So moving on to question 4. Again, on your chat box, what is your understanding of shared decision making? What is your understanding of shared decision making? You can type your answers in the chat box. What is your understanding of shared decision making? Karen says obtaining consent. Any takers on that? Priya, including patient and decision making, very good. Phil, good to have you on board, buddy. Dentist and patient jointly agree. Bronya, lovely to see you. Both clinician and patient work in partnership. Adam, provide recommendations, but maintain patient autonomy. Excellent responses here. Can't be prescriptive. Two-way decision making process using evidence, available risks and benefits. Excellent. Patient and both have to say explain options to manage. Good practice and treatment. Guys, you guys are on the ball. Fantastic. Okay, so no decision about me without me. So it is a collaborative approach. Both the clinician and the patient are involved in the shared decision-making process. Now, in the past, we've adopted a paternalistic approach where the clinician says and the patient does. But that really is a concept that no longer exists because we need to fully involve the patient. It is a process that gives respectful patients autonomy, respects patients' values, and it's based on scientific knowledge and basis. So there's got to be evidence for that. And it's a collaborative approach. Rather than it being a monologue, it is a dialogue, a two-way information process so that both practitioner and the patient collaboratively make a decision, a joint decision. Very often, sometimes patients will say, look, you decide, doc, you're the expert, I trust you. And there's no reason, there's no harm for the patient to say that. The reality is that in our clinical records, your documentation will be around the lines of, as much as I have implemented the shared decision-making process, the patient has decided to follow my recommendation, but the patient has given full autonomy to make that choice. So shared decision-making is a very important concept. And again, moving on from COVID-19, there will be more emphasis on that. And, you know, when we obviously go back to our practices, we will be adhering to what we've been doing all along, or I hope that what we've had in place. So standard record keeping requirements from name, contact details, date of birth, medical history, reason for attendance, etc. Our examination, our history of presenting complaint, if there is one, extra-oral, intra-oral examination, special tests, to the diagnosis of treatment plan, the options, risks, benefits, and consent, and then the treatment. Now, the additional aspect that I need to sort of reinforce to everyone here is that when we come back to our practices, we need to ensure that our documents, our record keeping is even more extensive, more detailed than before. And it will have to record things as follows. The PPE that we have used. So actively write down what PPE you and your nurse have been wearing, whether it's an AGP or a non-AGP. What other risk mitigations have we used? So, you know, rubber down for that particular procedure, high volume suction, what other ventilation procedures that you've implemented, and then the sort of the downtime between the appointments, start and finish of a procedure. These are really critical things, because should an allegation arise some months later where a patient alleges that I contracted COVID-19 from your practice, I was fine before, but a day or two after I started to fall ill, then it's going to be our records that will demonstrate that defense. And we need to ensure that everything is documented to support ourselves, because patients can seek an opportunity. So what treatment am I going to do next week? So central to the phase transition of dental services and resumption of all service provision is the acknowledged clinical judgment of practitioners. Again, the acknowledged clinical judgment is the key word, and their ability to risk manage the delivery of dental care. And again, that's the standard operating procedure transition to recovery. So patients that are not suspected or confirmed COVID-19 or the household contacts may be offered face-to-face appointments with the primary care dental practitioner. We may carry out both non-AGP and AGP care, subject to the availability of the appropriate and in line with infection prevention and control guidance. Suspected and confirmed COVID-19 patients requiring urgent face-to-face care are to be referred to UDC hubs. And patients including COVID-19 and their household contacts, patients that are shielding or at increased risk. So this is going back to one of the questions that anonymous attendee. I wish I could give you, and I'll call you AA. Let's call you AA, because you come on all my webinars, and I should assign a name. So AA. Are shielding increased risk need to be identified through an initial remote stage of the dental care pathway, followed by a face-to-face stage. Progression to resumption of the full range of routine dental care will be risk managed, ladies and gentlemen, by the individual practice, and can include AGPs, subject to the following necessary IPC and PPE requirements. So we need to take steps to risk assess the workforce and take commensurate actions. Now, we all know that over the last several sort of weeks, the bodies of the GDC, the CQC, OCDO, faculty, RCS, BDA, there is ongoing discussion and guidance. Let me tell you and reassure you, there is more to come. That's correct. You heard me correctly. Be prepared. There are going to be 40-page documents, 50-page documents, 60-page documents coming away. It's never ending, because things are changing rapidly. Things are changing daily. So on the 8th of June, if you're not already, training your staff or putting systems in place, the phones will be busy. Have you prepared your staff? We need to unify, train, and mentally support the team, because without our team, we are nothing. And they are the ones that are most apprehensive at present. And there's a lot of anxiety, a lot of uncertainty. Is the practice going to get it right? Or should we be seeing patients? How are we going to risk assess those patients? How can we be sure that I am not going to be implicated? I'm not going to be affected. I'm not going to get contracting the virus. And we need to support our staff. Those that perhaps are shielding, we need to understand their concerns. We need to, understand if they're living with vulnerable family members, they have the fear of losing jobs. So we need to have an action plan. We had to have ideas, pen to paper. We need to, put a plan together, because if we don't plan, we could easily fail. We could put others at risk as well as ourselves. There are going to be endless risk assessments. There are going to be a number of protocols that we're going to be putting into place, and we're going to be revisiting them over and over again, reassessing, reevaluating our checklists. What does it come to at the end of the day? It comes to communication. It comes to communication with our team. It comes to communication with the little man up here in our head. It comes to communication with our patients, and effective communication can be the solution to many things. And how you choose your words, how you discuss, how you convey the message, how you explain things to our patients in an open, transparent, and honest manner will determine how we move forwards. So I'm going to share with you some 10 tips for returning to practice. Number 1, training, reassurance, and direction. We need to consider the arrangements for our practice staff. We need to address the concerns. We need to be there to provide reassurance and support. Implement a strategy for social distancing where possible at the practice. And in a dental practice, that can be quite challenging, because in the actual dental surgery, there is no social distance between you and the patient. We need to limit the number of patients, and ensuring appropriate changes are made at reception and the waiting areas. Number 2, identify your initial category of patients. Consider the list of all those patients that have contacted the practice over the last 2 to 3 months for emergency advice. Make sure that we accommodate those patients first of all, because they're the ones waiting. They're ready, and we don't want any symptoms to progress. There are going to be those patients who are referred to the UDC, those next in line. We need to follow up those patients to see how they were managed, how they were treated, how the concerns being addressed. Again, depending on how the diary builds up for the next 3 to 4 weeks, appointments will need to be spaced down, allowing for ample time for cleaning, downtime. So you could be seeing 4, 5, maybe 6 patients per session. Step number 3, assess the PPE measures in the working environment. Consider again what is required. Make a list if not already done so. Look at what you have already in place. Before lockdown, a lot of us had reasonable amount of PPE, a varied amount of PPE. During lockdown, some of us may have already started to contact suppliers because we need to have the correct arrangements in place. Let's take a look at what we have. Is it enough? Do we need to purchase any more? What type of masks are we really going to go for? We're going to go for the FFP3 at £15, with the little respiratory valves. Or we're going to go for, the industrial masks that are perhaps more robust, reusable. Filters can be changed every 28 days or even longer, but the fitting of those still need to be tested. So we need to consider the alternatives. Step 4, rehearsal of dunning and duffing. Again, your staff need to be confident on the process involved. That should a AGP be planned? There's one coming up in a couple of weeks. Are they trained to dun and duff? These are sort of things that are essential. Let's not just assume that they are aware. Step number 5 goes without saying. Make sure your indemnity has been restored to its correct level. Some indemnities will automatically do that, others won't. In fact, if you're not in a position to open on Monday the 8th of June, and you kind of continue with the triaging process because you're either going through some refurbishment, you're waiting for the correct level of PPE, then the last thing was your indemnity to restore your levels of subscription to its normal. So you could be paying, I don't know, 1,500, 2,000 right now, suddenly it's pumped up to 8,000 from Monday the 8th of June. So the communication needs to be there. Equally, a phone call or an email just to explain to them that we are resuming normal services. Again, skeleton service, non-AGBs to begin with, face-to-face consultations, and so long as they're aware, and any risk, any complaint, any issue that should arise, you are appropriately indemnified. Step number 6, effective communication with your patients. This will be challenging when additional PPE will be worn. Imagine talking to patients when you're literally done that with all these masks, stealth masks, visors, additional masks, and gowns. You're almost going to be dressed up as a Dalek. Your movement, your body language will be restricted. So again, to obtain consent, we need to have effective communication channels in place, assigned more time. These things cannot be rushed. Don't forget, even when we do go back, patients want to be involved in the decision-making process. And 2 studies I can share with you both clearly state that over 95% of patients want more information. That's from Kaisler back in 2006 in Germany, and 96% want to be offered choices and ask their opinions. So there's going to be a collaborative approach that's going to be continued. Step number 7, reevaluate your services, consult your staff. Again, these are really important features, ladies and gentlemen. We need to implement this. You know, there are going to be times where staff will come to you with concerns, things that have come to light, and they want you to address it. You know, you're the practice principal, you're the team leader. We need to reassess and reevaluate the appointment diary system. It's not working. It's a complete mess. It's not allowing staff time in between to implement infection control procedures. Step number 8, schedule the next staff meeting. So you've had one last week, you may have one this week. Let's make sure it's regularly in place, because we are going to have to revisit what we've got in place. Amendments to our diary, amendments to the protocols will have to be in place. Let's log these meetings. Let's make sure that those staff members, perhaps who are not present, are involved. They receive minutes of the meetings, perhaps a Zoom video, remote services in place to include them because they're at home, whatever it may be. Let's make sure it's fully inclusive so that there is no confusion, no unanswered questions. Step number 9, continue to seek support from your peers. You know, never feel isolated. We have learned so much, ladies and gentlemen, over the last 10 to 12 weeks by speaking to our colleagues, exchanging ideas, you know, exchanging supplier details. We will face challenging situations from patients. There's ever endless changing legislation that we're encountering. So, you know, speak to your indemnity, speak to your colleagues locally, speak to your LDC and local peer review groups. And number 10, there's going to be a trail, an audit trail that we need to implement. We need to ensure, as part of our quality assurance, our sort of ongoing risk evaluation, that we have audits in place. And that's irrespective of whether you're working at NHS, private, or a mixed practice. You know, should there be a question raised, should there be a comeback from any of the bodies, we can demonstrate through good clinical governance, through quality assurance processes. Actually, we have been auditing our processes from reception to the waiting room, to the decontamination room, to the surgery, how we've managed the diaries from non-AGP procedures to AGP procedures, and the PPE that we've been implementing. You know, this will allow us to enhance patient care, the outcomes, and run a smooth, harmonious, safe practice. And as the pioneer of the practice, you know, as the team leader, you know, our team will be looking to us for answers. Problems will arise, solutions need to be in place. And even if we don't have the answer straight away, we're human beings at the end of the day. Okay, this return to work, this comeback, this whole COVID-19 crisis is a new ball game for everyone. You know, sometimes we don't have all the answers, and it's about being open and transparent with our colleagues to say, you know, yeah, I understand concern, I understand this needs to be addressed, let me look into this, okay? And based on all the latest and ongoing guidance, you will know when it's the right time to commence more routine, complex treatments, having risk assess your procedures in the practice. So don't feel that you're ever alone, ladies and gentlemen, because pretty much everyone is going through this, okay, together. And provided we remain unified, provided we collaborate with each other, provided that we support each other, then hopefully we can resume to our profession, a proud profession that we've worked throughout the years and looked after our patients. It is a business. Dentistry is always going to be a business that we need to run, and so we need to be mindful of the sort of the expenses, the incoming, the outgoing, the profit, the loss, because you know that's what the nature of our business entails, and we can't exclude that. And so as a result, we need to again make sure that whilst we're running the business, we need to be mindful of the ethical responsibilities that we have to our patients in line with GDC principle number 1. And let's be mindful of that guidance, okay? It's there for a reason. You know, considerable amount of work has gone into it. I am totally in agreement that there is endless guidance there. It is frustrating to receive one guidance after another. Let's follow that national guidance from the OCDO. It is there, it's clear, it's concise, and let's just make sure that you know, everyone adheres to that. And if we step out of line, if we don't adhere to those risk assessments and the standing operating procedures, then we're only going to be putting ourselves at risk. We know the press, media, and the patients are literally all informed about practices opening. we need to manage their expectations. Some conversations will be challenging, especially from those patients who demand appointments and those who started treatment before lockdown. We need to approach those patients with empathy, with understanding. Many want to discuss their ongoing treatment. Concerns will be expressed by those who want their oral health not to be compromised. Those patients will need your time, explanation, reassurance. And again, those conversations will help our patients to recover psychologically because they've been affected from this as well. Not just us, they have been affected. So it's a two-way process. And now with GDC, it's an essential and expected part of our role as a caring and ethical dental professional. Again, I'm sure many of you have seen this, lots of notices issued by the NHS. Print them, display them in your practices. They need to be there because there's some very clear, excellent messages in these notices about how we're going to manage the return to work, how we're going to manage the sort of the volume of patients, how communication needs to be in place, that the fact that there may not be the same range of treatments that will be offered compared to previously before lockdown. So again, treatments may vary from practice to practice, depending on staff, equipment, PP availability. So these notices do spell out some very good, strong messages. And again, if you're told to visit your dentist, you may notice those changes. Again, practice looks different, the setup, the arrangements of reception, the communication channels, the distancing, the way the dental team are dressed up when we're greeting those patients. We've seen this is on the left, issued yesterday. BBC News warned that there will be no return to business as usual. Practices could reopen from the 8th of June. But again, until we communicate and educate and inform our patients as to how our services will be resumed, to what capacity it will be resumed, they will not know. So, it's going to be a rough ride to begin with, but so long as we're not inundated by overbooking in our appointment diaries, we can manage these effectively.
Later. Let's see, time now 6:48. Dentists across England will be allowed to start seeing patients again from Monday, but the British Dental Association says that shortage of protective equipment means many of them will remain closed.
NHS England insists that it's continuing to work with dentists on safety, as Dan Johnson reports.
Is the Bailiff British Dental practice. The surgery is now closed.
Empty surgeries and patients left in pain.
Normal surgery will not be resuming at this time.
Dentistry felt the lockdown more than most,
despite the government's announcement.
And now there's a real struggle to reopen on Monday.
Unfortunately, there won't be any patients here. We're hoping that a week's time, we might be able to start seeing some of our own emergencies and do some very basic treatments. Normal dental treatment is not going to be happening for an awfully long time, but this waiting room is going to be empty for months.
And even then, ensuring the virus doesn't spread will have a huge impact.
I'd normally see between 50 and 60 patients on an average day.
And what about now?
Now, when we start treating people and doing proper treatment with the drill, I think the most up.
Okay, just to speed things along, you can see very clearly that practices are not going to be ready. 36% of practices apparently will be opening from Monday. By the end of June, 60% of practices will be opening. So BBC News have obviously televised that. Not all our patients would have probably captured that. Again, it's about us making sure that they understand from our perspective how we intend to resume, how long it will take. Surely, but slowly we will get there. So it's all about balancing the probabilities of risk. And again, goes without saying that we need to brace ourselves. The UK, the Prime Minister has already warned of a second spike. It may happen. More often than not, we find that these things do happen because it's happened in the other countries. Dentistry may start off for a few weeks and suddenly we find we're back to square one and we're asked to close. So again, we need to be more risk averse. We need to be vigilant. We need to adhere to the guidance and implement whatever safety precautions and infection control precautions in place, because it's our ethical and legal responsibility to our team and our patients. So let's be prepared. ladies and gentlemen, not unprepared. Monday, the 8th of June is coming. For those that will not be reopening, there's absolutely no harm in that, because you're allowing more time to get together with your teams and put things into place. That's absolutely fine. CQC, GDC will not penalize practices for that. Only when you are ready, you will know that it's time to open those doors. I want to end with a quote from Sir Winston Churchill: "He who fails to plan is planning to fail." And really, that encompasses everything that we do in every walk of life. So I'm going to now open the floor to questions and answers. I would like to take this opportunity to thank you. I know you've been hanging on. It's gone well over than expected, but I did say to Kaushik and Darshan that I want to give as much as information, share as much as I can with the audience, because ethical and legal considerations is a very important thing. It's a big event for us going back to work, and I hope very much that you have benefited from that. And thank you for participating and bearing with me. Thank you.
And before Darshan can take the questions, I just quickly run over. Shaam, thank you so much for being such a good speaker today. I think a lot of us are coming from a sort of a general practice background. For us, there are two sides of the story: being ethical, having ethical practices, having honest communication, and then still be financially successful is always the balance that we always find it very hard to get. You coming from the practice background, you doing general dentistry yourself, I think we wouldn't have found a better speaker to explain it to us in a much better way. You have done that, and we at Dental Routes believe a lot in terms of trying to create a robust platform for all our members, so that we have very ethical practices all the time, so that we have a very honest communication with our patients at all times, and also have a very financially successful schemes and processes as we go forward. On that line, we are working with Shaam to create some kind of a hand-holding process for all our members as we go forward, because a lot of times, even though it is all well formulated and so nicely spoken out, trying to get it to practice can be quite a daunting task. And mainly with regards to creating secure processes and trying to prove that we have, a lot of us do have very ethical processes and honest communication, but we are not able to prove it to the people whom we need to prove when it comes to the verge of we having to prove it. And this is where Shaam could be a very, very, very good person to hold our hands and then give us the right guidance on how we can implement.
Kind of insight that you have given us. Although I do have some questions for you, which might be slightly off the topic of all the discussions that we've had. One of it was about the vulnerable group of dentists regarding how they can expose themselves to clinical care. I had a small idea regarding how, if you, I thought I'll probably let you answer this question best.
Yeah, absolutely. Consideration has to be given to dentists who fall under the vulnerable group, because it's all about, making sure that when we return to work, we're not putting ourselves as well as the others at risk. So if you are vulnerable and there is a slightest degree of hesitation about you returning to work, the safety protocol is don't return to work. Now that may not be a very logical answer, and again, every practice will have to look at its sort of circumstances, the arrangements that are in place, the number of team members. If there are arrangements in place to have adequate manpower, then that can be pretty much a good solution. But if you're a smaller practice and it's very heavily reliant on you as the main dentist or one of the dentists, and you fall into the vulnerable group, what we don't want is to put other people at risk. And this is where your risk assessment comes into place. And in any situation where you feel that as much as you want to return, but that risk is very high, I would urge any one of you to contact, obviously, your indemnity regarding that situation. I would also speak to, if you're working within the NHS sector, to speak to your local area team and say what arrangements, substitute arrangements can be made, because what we don't want to do is leave our patients unattended. So there are a number of things to consider there. Ultimately, your safety is paramount. The safety of your family members is paramount. The safety of your team and your patients is paramount. There's a lot to consider.
Oh, that's a great answer, and I completely agree with you on that. And you've had some amazing feedback. I don't know if you've been reading it as well, but people have taken your lecture to heart. Really, I think considering the times and the situation, you've timed it perfectly, and the amount of comprehension and information you provided has given them a great insight, I guess, into what the next steps are going to be. There are some other questions that you answered the idea about the KN95. I guess the KN99 is the FFP3 mask, and the KN95 is the FFP2. So I suggest kind of clarify that if any of the attendees are unsure of. But apart from that, no, that's pretty much the questions that we've had. I hope that answers your question, Imad, because that was Imad who was asking you the question about the vulnerable group.
Absolutely.
Excellent.
So that's wonderful, guys. So we had a wonderful session today. I don't know how much I should thank Shaam. He's been such a wonderful person to have on Dental Routes. He's taken out this time from his very, very busy schedule. You know how many hats he's going to wear, and how much time he has to be spending on all those things. And he still made time for us to make sure all the members get the best out of the situation before they get back to practicing dentistry again. Thank you very much from the Dental Routes team, Shaam.
Thanks a lot, Shaam.
Thank you very much for inviting me, guys.
Thank you, Darshan, for your thoughts all through the paneling today. Thanks a lot for Jay, who has been our backbone all the time, trying to make sure everything is hosted properly and there is no disturbance anywhere. And the rest of the Dental Routes team, including Dr. Senthil and our technical team. So guys, going further, we'll see you all next Saturday. Till then, all the best for you guys to get back to business. And we will be there to support you for anything you want. So your feedback is very, very much appreciated. We take them very seriously, and we conduct our courses on the basis of your needs. So